Well, good morning. Happy Monday, or good afternoon. It's morning my time, afternoon yours. I guess excitement because we're finally coordinating this webinar. So we're just going to go through the VELscope, how it works, what we're looking at, um, to help you understand that this is a tool that assists you in doing everything you do every day. It's just giving you more information to allow you to assess what's going on and hopefully better manage the patient. What I would ask you to do is, I guess, text me if you have some questions as we go through, or write them down so we can remember. So obviously, the reality is, I think it's really important. VELscope is not a diagnostic tool. It's a screening device. So what does that mean? We're hopefully screening to detect abnormalities that could potentially be cancerous. So our goal is to prevent cancer from occurring in the first place, just like we want to prevent breast cancer or cervical cancer by screening and finding something hopefully at an early stage. Put this into context, and I think it's really important because I've been with VELscope for over 11 years now. In that period of time, the numbers have only gone up, even though I would say overall we're more cognizant of the issues associated with oral cancer, but the numbers aren't going down. In fact, if you really look at it, they're actually going at a faster rate in terms of the number of cancers being detected. And it's unfortunate because, unfortunately, what we're seeing is these numbers are being associated with a younger and younger population. One of the things that I would ask you to think about, and maybe in a scenario where you have a patient who's a little more academic, a little more conversation about understanding what it is that you're offering, a question you might want to ask them is, Mr. Smith, what do you think are the top cancers? Most people will say breast cancer, colon cancer, cervical cancer, skin cancer, lung cancer, for instance. What they'll rarely ever do is put oral cancer in that top 10. And I think it's important because part of your, I'll say, responsibility is to educate and to assist in increasing awareness, because at the end of the day, it's this education awareness is really going to be the way to reduce the amount of oral cancers that are being detected. Oral cancer is now the 6th leading cause of cancer among men, 9 among women. And, putting that into context, most people think cervical cancer is the top 10. Obviously, ladies in the room get a pap smear on a regular basis. And really, the only patients who get cervical cancer are patients that don't get a regular pap smear. Our goal is to make this like cervical cancer. We want to get to the point where we can reduce these numbers significantly. We're all cognizant of the connection between cervical cancer and HPV. And now we should also know that HPV is a leading cause for oral cancer. The challenge for you as clinicians is it tends to cause more changes towards the back of the throat, lateral borders of the tongue. So it makes it even more difficult to identify these changes. And that's, I think, one of the other reasons why we need a device like VELscope to assist in identifying those changes at an earlier stage. So the connection between oral cancer and HPV has been fairly known now for at least, I would say, 7-8 years. And some of the initial studies were associated with the transmission of the virus via oral sex. But what they found is the virus can be transmitted just through open mouth kissing, meaning, it sort of makes sense, tongues touching tongues. And because of that, we have to make the assumption that everyone is at risk. It doesn't matter if they're an 18 healthy individual who has Gardasil, because the reality is that they're even finding that people that have been inoculated haven't necessarily had the right series of inoculations or within the correct time frame and so forth. So we just want to make sure everyone is getting screened, whatever you deem as being an adult, 18, 16 and above. And from that, we're going to hopefully identify those changes sooner. There's a study that actually has come out that shows that, actually several now, but in one specifically that talks about they believe over 56% of all oral cancers now are associated with HPV. And because of that number, they believe, is only going to go up. And that was, obviously we've seen smoking decline and so forth, but oral cancers are going up, continuing going up, and that's we believe associated with HPV. So obviously all the risk factors are critical, and something you're assessing in patient history that you know of. You don't know who's infected with HPV, so we just have to, well, I shouldn't say that, obviously, for some females that have been tested positive, but, with the assumption we don't know, let's just assume that they are. So who are we going to screen? All patients, generally, that you deem as being enrolled at least once a year. If you have a patient that is of a higher risk profile, a heavy smoker, maybe someone has been diagnosed with HPV, you may want to consider screening them more frequently. But again, that's going to be between the hygienist and doctor as to the frequency of those screenings. So as I referenced, VELscope is part of your examination process. And so it's critical that we do what you do every day in terms of understanding what the patient's health situation is, medications that they're taking, a history of oral abnormalities that they're cognizant of, surgery and so forth. Now we do our white light examination. We see something suspicious. We're going to ask the patient questions about what's going on. How long have you had that lesion? Did you jab yourself with something that caused that sore spot? And now we do our VELscope exam that gives us more information. So VELscope's part of your overall examination process that gives you information to say this is something of concern or not. It really is that simple. From that, it is of concern. You follow your processes, whether that's 2 weeks or whether that's refer right away, depending on how it presents itself. And then obviously you're going to manage that patient appropriately. So, if you look at the literature, 30+% of your patients have some form of oral abnormality, whether it be cheek biting or fibromas or what have you. And we're not referring those 30% to oral surgeon every day, and that's because you're assessing what it is, what the risk factors are, and so forth. And so because of that, we're not changing your processes or protocols, and hopefully we're just giving you more information to assess, is this something that requires appropriate follow-up with a specialist? So we're going to talk about, obviously, the goal is to find things early and as soon as possible. So my understanding is you're definitely charging, and, as we present this to the patient and the patient declines, our normal inclination is to perceive that the patient is declining because of cost. And in the majority of cases, that is probably the case. I think it's really important to understand, however, that it isn't always the case. So if a patient declines, it's always important to ask why. And you tend to find this more with people in the medical field or engineers. Hey, I've never heard about this before. If this has something to do with cancer, how come my physicians aren't doing this? So, a simple response can be, Mr. Smith, this is actually an FDA-approved device that has shown to assist clinicians to find things early, like a mammogram does, if you will. And from that, it's been well documented, tons of clinical evidence to support the efficacy. Another thing that you can use is this is standard of care for lung cancer screening. It's actually been available in that arena, if you will, for over 20 years. And basically this took that technology for lung cancer screening and incorporated into this device called the VELscope. So again, really important. So if they say why, it's important we ask why and understand the reasons behind it. And if it seems to be skepticism, gimmicky, response, I think this is one way to address it, the FDA and how it's been used in other medical fields. So our VELscope exam, again, we've done a white light exam, patient history. Now we're doing our VELscope exam. The goggles are for the patient. This light is safe for the eyes. It's not like a curing light, but it is bright. And because of that, we always want to make sure that we're, just for patient comfort's sake, assessing what's going on. So from that, one of the things, that I would say is we want to make sure that you're doing your same protocols up and down, left and right, for the mouth, back of the throat. You can see the distance that the clinician here is, so 2 to 3 inches from the oral cavity, and there's a little paper cap that you're going to use that we want to change for every patient, because you'll touch the patient's mouth, you'll get saliva on it. If you notice the clinician here has his eyes up to the handpiece, it is not required. I think sort of that's your normal inclination. But if you wear loops during your white light exam, I would suggest continue to do that same protocol. Just establish your normal distance first with your loops on, and then you bring the VELscope in, again, being about 2 to 3 inches from the mouth. And there's a slight learning curve, just getting comfortable with your angles and direction, but I think you'll find over time it's going to be easier to continue what you normally do in terms of your examination processes. So it's about finding things below the surface. 70% of all oral cancer, unfortunately, is found at a late stage, and which is why, unfortunately, the mortality rate has not really changed in 30 years. Obviously, our goal is to find it in a pre-cancer state, preferably the earliest possible pre-cancer, and that way we can address it and avoid it from becoming cancer. So, again, this goes back to my question: when the patient declines, we ask why, and if they say, well, I've already had, you just did x-rays on my teeth, so their concern is about radiation or damage to cells. And what we can inform them is this is completely safe. There's no radiation. There's no damage to cells. There's nothing that's going to cause discomfort. It's a safe blue light that basically has a certain wavelength that's absorbed by the tissue, specifically for us, so for your knowledge, collagen in the basement membrane. And when that tissue is normal and healthy, it actually gives off a response, and that response is called fluorescence, which we capture through the handpiece, or filters in the handpiece, and that basically tells us if the tissue is normal or abnormal. But again, just reinforce your patients that it's completely safe, and there's nothing to cause discomfort or pain, or again, radiation exposure. So I referenced some of the things that are involved with the absorption of the tissue. So we're identifying actually a variety of things that are associated with the tissue that tells us everything is normal, abnormal, from healthy collagen to actually healthy metabolic rates in the cells. When we have dysplasia or cancer, it absorbs light, but it can't respond anymore. So instead of seeing green when we look through the handpiece, we now see dark or black. Now, it's important. We don't know what that is. We don't know if that's minor dysplasia or full-blown squamous cell carcinoma, but we know there's something abnormal there. But it's also, we have to understand things that cause, if you will, a dark response. Besides dysplasia or cancer, melanin, so African Americans, Asians can have more pigmentation, for instance, especially in their gums, and hemoglobin, which is in blood, also absorbs this wavelength, which is actually a great tool for us to assess what actually that abnormality is. Is it trauma, inflammation, or something that could be dysplastic? So this is what we're going to see in 98% of the time, nothing but healthy green tissue. I referenced the hemoglobin, and that's what we see here in the vascularity. But again, we have to utilize your clinical understanding of how cancer presents itself, right? So we know cancer is going to be unilateral. It's going to be a regular shape. It's going to be persist for 2 weeks. Here you sort of see sort of red tonsillar area, which doesn't seem overly, bad. Under VELscope, that hemoglobin is going to be absorbed and it's going to be a little more pronounced, but we see it's bilateral. Again, you see that vascularity, which is, again, the hemoglobin. But it's a great opportunity to say, hey, Mrs. Smith, you have allergies, you have a cold, sore throat, something, and, number one, to confirm, but then secondly, sometimes we go, oh, how'd you know that? So it's really important, again, understanding how cancer presents itself. And we know from our teachings, if we will, cancer doesn't present itself in polka dots or little circles or shapes. Again, it's going to be isolated. And so if we notice here little polka dots on the tongue, that's just increased blood flow to our taste buds, right? Hemoglobin, that blood flow. And some patients will be more pronounced than others. Also, we know that it's pretty rare to have something on the dorsal surface tongue. Now, here is an area of greater concern that says, hey, something's going on. Mrs. Smith, do you have a sore throat? Do you have allergies, something that's causing some irritation in the back of the throat? Not really. Not that I can tell. Why don't we have you come back in 2 weeks, make sure everything's okay. from that, patient comes back and it's still there. Now, overall, we're not overly concerned, and the reason being is if it was just this black mass by itself, we'd be concerned. But the fact that we see, if you start looking, it'd be too obvious if I had this full black picture of the back of the throat. But if you start seeing, you can start seeing a lot of little black dots. So again, cancer doesn't grow randomly like that. But this is abnormal. We don't know what it is, Mrs. Smith. I'm going to send you to a specialist to get it checked out just to make sure everything's okay. Specialist says, hey, I don't know what it is. The only way I can find out is via biopsy. Comes back as inflamed lymph node tissue, which doesn't seem bad. It's not cancer, thank God, but it's not really a diagnosis, right? It's not telling us what's going on. So additional testing, and to come to find out this patient had severe acid reflux and didn't even know it. And so to help you understand the benefit that we're offering your patients by screening more effectively, the fastest rate of cancer right now is esophageal cancer associated with acid reflux. So you will see this, and you'll see this pretty regularly, and this provides an opportunity. And you'll see these polyps right in the back of the throat. You know, Mrs. Smith, you have acid reflux, you have postnasal drip. Sometimes you'll see some irritation associated with that. You know, if you don't know, maybe you should see your physician about it. If you do, maybe you should see your physician about getting that medication changed. But again, provides an opportunity to take your interaction with the patient, I think, to a different level. And more importantly, get it checked out and treated appropriately. One of the things you're going to see very frequently is orange, especially on the dorsal surface of the tongue. It has nothing to do with cancer dysplasia. It's just a bacterial byproduct, if you will. But it's a great opportunity to have a discussion with your patients about their hygiene and maybe better ways to, you know, get that bacteria, if you will, especially off their dorsal tongues, which we can talk about in a little bit. So one of the other colors you're going to see pretty frequently is light green or almost white in color, which actually is a condition, a benign state, but doesn't mean we ignore it. We always want to figure out what's the cause. Are there some sharp edges of the teeth? You know, this is the case where the patient's tongue was getting caught between their teeth, which again allows you to address it. So as I mentioned, pigmentation is absorbed by this wavelength. So African Americans, Asians tend to have this more frequently. So we see this clinically, and this obviously, it looks pretty comparable to what we see under VELscope. Same thing with this amalgam tattoo. So we sort of have to identify what it is we're looking at clinically to understand and why we should feel comfortable with what we see under VELscope. So one of the things you're going to see pretty frequently are irritations or sore, just through normal, you know, patient wear, if you will, biting, eating something hard, hot tea or coffee. Denture sores is another example. And so when we see something suspicious, you know, the first thing we want to do, and most of the times you're going to see this clinically, is to ask the patient, hey, did you do something recently? You know, I see this red spot under your denture. Is it sore? Is it uncomfortable? But then what we want to do next is, as we look under VELscope, we want to take our Explorer or back of our mirror and gently rub across it. And if we see it turn green, what that does is that tells us that this lesion, if you will, is benign. What we're doing is we're moving blood out of the epithelium and seeing a nice healthy basal membrane. So that hemoglobin we see is just associated with inflammation. If this was cancer or dysplasia, it would stay dark. And so this is a great way to direct how you're going to manage this patient. Okay, denture sore, let's adjust it, have you come back if need be. It's dark, we're definitely having you come back because we want to see what's going on, and then obviously take appropriate steps. So again, a great way to assess what you see every day and confirm, as opposed to assuming it's trauma or inflammation, and with that appropriately care and manage the patient. So when we have an open wound or sore, it's really important that we can assess what's going on. So if we don't have a basal membrane, if we will, because we have an open wound, we're not going to be able to blanch across it. So that's where you're going to use your normal clinical assessment tools to determine what to do next. And from that, you know, this doesn't look good, obviously you may want to consider referring out. But again, if we can't blanch it, we can't tell you what it is. So anything open wound, bite, open source, something like that, you're going to have to follow your normal clinical protocols. So we have something like irritation, very common, lateral border of the tongue here. You see this little dark line. What I would say is that, number one, this is linear, so cancers will grow in a line, right? These tend to be bilateral, and these tend to blanch pretty easily, too. But there's something going on here. Why is this dark? So what we know there's something irritating, if you will, the tissue that's causing this response. And so this is where I would suggest you use this as a tool to manage the patient. Take a picture, show the patient, Ms. Smith, you see this dark area, this should be green. This is an indication of inflammation that can lead to changes that potentially we don't want you to get. This tooth that we've been saying you need to get a crown on for a while, we really need to get this taken care of and reduce that need for reduce that irritation that sharp edge is causing. So again, use it as an opportunity to address that inflammation and trauma that could be caused in certain situations. And this would be another example of that. This is going to be the most common thing you're going to see with VELscope. It's going to be irritation and trauma associated with cheek biting or cheek sucking. And from that, normally you'll see the linea alba lap, but what you won't see is the gray or the dark that you'll see around the linea alba unless you have the VELscope. And so again, a great opportunity. And I would say if you're using this regularly, you should be making recommendations for night guards. With the recommendation of Ms. Smith, you see this dark here. This should be green. This from your biting, which you probably don't even realize. Biting your cheeks, which you don't realize. And, one way to hopefully reduce that trauma is to get a night guard. So another way to assist that patient in, again, improving their care. So just because we have something that blanches, so this could turn green, awesome. That gives the indication it's not just plastic, but this doesn't look normal. So regardless of what VELscope says, at the end of the day, you and the doctor have to assess what it is and achieve some type of diagnosis. And if you can't do that or feel comfortable making a diagnosis, please refer to a specialist to get one, because you're going to treat erosive lichen planus differently than you're going to treat candidiasis. And erosive lichen planus actually has a high probability of progressing to dysplasia. So again, always try to achieve a diagnosis regardless of how it appeared, whether it's dark green, light green, white in color. We should always understand what's going on and what the potential cause is. So this is an example of a lesion that doesn't blanch. So when they rubbed across it, it stayed dark. However, before they even pulled out their VELscope, they looked, looking under white light, they could see that the lesions were present, which led to questioning, Ms. Smith, I see something on the side of your tongue. Do you know how long it's been there? Oh yeah, I bit the heck out of my tongue last night. So that gives an indication, probably some trauma. And we know that cancer doesn't sort of grow in some type of multi-dot formation, right? But this is actually the one they were more concerned with, because it has more of that characteristic of an abnormality that obviously could be of concern. It wasn't blanching, so they had the patient come back in, and it was resolved. It went away. And so what this was an ecchymosis. It was a sort of like a deep bruise that hadn't broken the surface, if you will. So, again, it's really important to get all that information before you decide to refer or determine what to do next. So that blanching technique, we need to know what it is. So if we're not sure what an imago tattoo is and it doesn't blanch, you may get overly, concerned. But obviously, anything pigmented is not going to blanch, and you're going to follow your protocols appropriately. It's important to blanch the entire lesion. Just don't go down the middle and say, oh, turn green. You really need to go up and down, left and right. You want to see that entire lesion turn green, because you may have inflammation associated with dysplasia. So one of the questions that, we'll get, and you tend to get this more, in all honesty, unfortunately, from like oral surgeons, and that is, oh, there's too many false positives with these devices. And the reality is that's completely inaccurate. Number one, it's a screening device. So there truly aren't any false positives, but it's important to understand what this does and the process associated with it. We're identifying abnormalities just like you see every day. And in that process of identification, you're going to go through your assessment Now we're incorporating that blanching technique along with your normal clinical assessment processes. And by the end of that 2 weeks, you have a lesion that doesn't blanch, no reason or cause for it, no appliance that might be malfitting or ill-fitting. That then requires a diagnosis or at least a second opinion to assess what's going on. And hopefully, God willing, it's not cancer. But we always stress, though, it's important to make sure that if you do refer, always get a diagnosis. I think some clinicians, it's like if it's not cancer, it's a false positive. And the reality is there's 99 plus diagnoses that are listed in the American Academy of Oral Pathology, and feel pretty confident that something that's abnormal in the VELscope is going to have one of those diagnoses. But most importantly, we're just making sure that we are finding things early, and hopefully you shouldn't have any concerns about any false positives. So when it comes to VELscopes, now think about what you see clinically under white light in that process. We're pretty much doing the same. We're now just looking through the end of through the VELscope. Here's an area, nothing that overly stands out, if you will, a little squiggly white area. But now under VELscope, it's much more of a concern. This is unilateral. It's a regular shape. It does not blanch. It persists for 2 weeks. And from that, this says, you know what, we need to get this checked out by someone. And unfortunately, this comes back as CIS, which is awesome. And awesome because this isn't a full-blown squamous cell. So we caught it right before it transitioned to that full-blown squamous cell carcinoma. This patient was referred for the polyp, but they got there. If the polyp wasn't for the polyp, they may not have found the dysplasia or the cancer located adjacent to it. Here was an area where the patient obviously has a denture, and they were concerned about the area here in the vestibule, and assumed it's just associated with the denture, but was adamant to have this patient come back in 2 weeks after they adjusted. And if you notice, sort of this area changes a little bit. It's a little more linear, but when they rub across it, it turns green. So basically, that just confirms irritation associated with the ridge of the denture, or edge of the denture, excuse me. But here on the ridge is actually the reason why they wanted the patient to come back in 2 weeks, because that was the area of concern that didn't blanch and required then follow-up that comes back as severe dysplasia, which is awesome. So again, we caught it in a pre-cancer state. So all these leukoplakias we tend to see and we tend to observe. These were two that were in observation mode for over 2 years. This first one we're not observing anymore. This is unilateral, it's a regular shape, does not blanch. Anytime you see something with really clear borders, that's always a red flag. But fortunately, again, we caught this at a precancerous state, which means no radiation, no surgery, no significant surgery. We're probably going to have to remove that top layer of tissue, but no chemotherapy as well. So again, not just increasing the likelihood of survival, but all the trauma associated with treatment is also going to be avoided. So here goes the lesion, actually a little more pronounced. Under VELscope, it's green. So hyperkeratosis, the linealbas, lichen planus will show up as green or light green. Now, it's important. It doesn't mean we ignore it. You always want to figure out, is it a sharp cuff that's causing, a sharp edge is causing it? Is it allergies, patient biting their tongue, something. So I always want to try to figure out what the causes are. And if it's still there in 9 months, 12 months, whatever, the doctor determines how they want to solve, it's okay to refer, but you're referring with a strong sense that it's a benign lesion. This patient was referred to NYU for the hemangioma in the lip, and when the oral pathologist applies VELscope, you can see the dark area on the floor of the mouth, and then send us back the picture. So, probably the doctor was so focused on the lip, didn't notice that area. But I really like this picture because what this says is, if you didn't do if you did a VELscope exam, you're not missing this. Shows up. So as soon as you turn that light on and present it to the tissue, if there's something abnormal, you will see a response. If you did see this, and let's say the patient declines, my suggestion is you're going to do a VELscope exam anyway. And so you can say, hey, is this something of concern? And unfortunately, this was actually a stage 1 squamous cell. So this is something that's already cancer and it's slightly visible, right? So that's, again, our goal is we're going to try to find it before it's visible. So here's another precancerous lesion. This is, again, our goal, and this is really where I think this indicates the true power of the device, because this is what we're trying to find, these precancerous lesions. Again, a lot of things you're going to see in the VELscope are going to be benign. So, famous picture, unilateral, irregular shape, persists for 2 weeks, does not blanch, and this is a carcinoma already. So this is already a cancer, and it's hard to see. So, I think this picture says it all in regards to the potential impact that VELscope can have in terms of assisting you in finding things early. So I don't know if you guys have a iPod or a camera. I don't know if you can type that. Whether you have a camera where there's a special adapter that you can hook on, or if you got an iPod, we now offer a system where there's a special adapter that attaches to the back, and then you put an iPod Touch to it, and that iPod Touch allows you to take a picture. There's an app you download, and then you can put information about the lesion, the size, color, location. It's all HIPAA compliant. You can store it on the iPod as well as download it into the patient's chart. Okay, so you should have a special adapter. If you don't, you might want to talk to your purchasing department, but the concept works the same way. Is you attach the camera, this adapter to the base of the camera, and then it sort of screws into the back of the VELscope. You have to adjust sort of the settings a little bit, but now allows you to take a picture. So if you want to, especially if it's something that's not obvious, so you can send it to the specialist so they have some direction as to where to potentially take the biopsy. And then from that, obviously you have something on record as well to follow. And then again, my opinion is take pictures for conversation with the patient also can be beneficial. So, so this is just an example. If you have, I don't know what, I'm assuming you probably have a small percentage of denture patients, but what we have a large group that does basically nothing but dentures. And what they found is when they use VELscope to assist in that adjustment, where, they have patients coming in regularly for readjustments, they found that VELscope identified these sore spots faster and easier, and from that they will reduce their adjustment periods or readjustment visits, if you will, from over 3 down to 2. So obviously it saves time and money. This is one thing that I would definitely recommend, and again, where they play with your camera, because again, feeling from another group, what they found was that they would take a picture of the red on the patient's tongue. And I'm using this as their terminology. So, but basically, Mrs. Smith, you see this red, this is called porphyrin, or in other terms, layman's term, bacteria poop. And from that, it gives you the ability, what we believe is important is sometimes your handheld toothbrush just isn't effective in terms of getting all that porphyrin off the tongue. So, what we find is the mechanical toothbrushes we offer actually are more effective, or can assist with getting not only cleaner gums, but also a cleaner tongue and mouth as well. So just a tool to assist you in communicating the benefit to the patients. So there's tons of clinical evidence on the VELscope so that you can peruse it. I'm not going to go through them all, so just to save time. But if you have any questions, or if anyone else has questions, whether it be patients or referrals, you go to our website, and again, you can find tons of clinical evidence, 30 years worth of studies to support the efficacy of the technology. So again, our exam, if you can turn off the lights, it'd be great. You're going to see greater contrast, but it's meant to be used in a fairly lit operatory. Again, this is an example of the distance you would have if you were wearing your loops. But we've done a white light exam, obviously internal and external palpation, Q&A, up and down, left to right. My only suggestion is that you'd want to try to be as perpendicular. So think about how we look at the cheeks under white light. We tend to retract them and sort of look straight ahead. What my suggestion is, turn the patient's head so that you're now going to be perpendicular, so contralateral to the side you're going to look at. Same thing with the tongue. you obviously only have one hand if you're used to using gauze in your mirror. Obviously, you can't do that anymore. So if you have a patient that might have a little more thicker tongue, have them stick out their tongue and tell them to put it to the left or the right, and then you can use your mirror to get more exposure, obviously for the posterior back of the tongue as you're looking through the VELscope. Your learning curve is going to be about 5 to 10 patients, because usually it's just getting comfortable with your angles. So my recommendation, if you haven't been doing this already, is, make sure you're screening everybody within the office back to back, or just do a day straight worth of screenings regardless of patient's pay. And I guarantee you by the end of the day, you're going to feel a lot more comfortable in terms of your location and distance. So I'm sure you're familiar with the code for reimbursement. It's not readily covered, which is why the critical aspect is how we present this to the patient. You should have got some brochures in your materials, and I'm just going to share one thing that I know is has been successful. I'm from an office, rural Kentucky. They get over 90% acceptance, and they think they charge a little over, I think it's a little less than $30. But what they were able to do is just try a variety of different things. And what they found was the most important was providing information when the patient's checked in, whether it's the patient brochures or a lamination, but something that gave that patient an opportunity to read about what this is, and most importantly, achieve a value. And also, if we can educate them up front, it saves us time in the back from having to educate. So, dealing from them, this is an example where the front desk person would give, when they checked in, they were giving them a brochure and saying, hey, take a second to read. If you have any questions, you can ask the doctor or hygienist when you go back. So instead of reading People magazine, they're reading about, obviously, what VELscope is. They're reading about HPV for the first time in the connection. They see a picture. So now the patient goes back, Mrs. Smith, do you have any questions? Did you read a brochure? Shall we move forward? Generally, your responses you're going to get, well, how does it work? Does it hurt? Those kind of things, which I'm sure you can explain. They say this, we're just looking at the tissues, completely safe. But from that, I think this was a great response. So if you go to Delta's fee schedule, it shows $65, which they rarely reimburse. But you guys do provide a discount. Mrs. Smith, our normal price of the procedure is $65. But you know what? The great thing with your insurance, most going to pay out of pocket is $40 or $45, whatever you're charging. And what you find is it gives that sense of a discount, which in a sense you are. But secondly, I think what's really important, and one of the things that they found was critical in this whole presentation, was using the word great. The great thing about your insurance, the most you're going to pay out of pocket. Because if it's covered, it's covered. If it isn't, it isn't. But then you're not wasting, I shouldn't wasting, but then you're not going through the process. Well, can we see if it's approved? Getting it pre-authorized for a $40 procedure tends to be somewhat limiting. So, the process of referral is going to be the same. Obviously, 2-week follow-up, pictures and so forth are going to be helpful. Lastly, I will just share with you, there is a service that we have available. If you see something suspicious, you're just not really sure what to do. If you take pictures under white light and under the VELscope with the camera, obviously history of patient, smoker, drinker, age, so forth, does the lesion blanch? It's really important to know patient information, so we don't need to know the name, just the age, for instance. And if you send that to us, we actually have it reviewed by, I'm not lying, world-renowned oral pathologist that will assist in providing guidance as to what to do. And it doesn't have to be VELscope-related pictures. It could be anything. It could be something you think is erosive lichen planus. But that is a service that we offer at no cost and available specifically for your group. So there's more information and training materials online if you so desire. At the end of the day, all we want you to do is determine what's normal and abnormal. And if you really follow those guidelines, you don't have to be an oral pathologist. You don't have to understand what something looks like under VELscope that's erosive lichen planus versus candidiasis versus dysplasia. You just have to know that criteria. And if you do that, it makes it so simple. So I'll leave it open for some questions, if at all possible, or if you want to email me with some questions that you may have, or type them in. I'm here for you. I thank you. I will make this, I should make this available for review later on, so I can send you a link that you'll be able to download if you so desire. And again, in the meantime, if there's any other questions that you have or need additional assistance, don't hesitate to give us a call. And thank you so much. And with that, enjoy using the VELscope. Take care.